Good evening, everyone. On behalf of Maharashtra Academy of Pediatrics as well as Catchet Pharma, a very warm welcome to all the respected seniors and colleagues on Zoom as well as YouTube Live. Friends, we all know that calcium is very essential for our overall health. We also know that it is a super nutrient, very essential in muscle contraction, oocyte activation, building strong bones, teeth, clotting, nerve impulse, transmission, regulating heartbeat, fluid balance within cells, and so on. The requirements are greatest during the growth period, such as childhood, during pregnancy and lactation. Long-term calcium deficiency can lead to osteoporosis, rickets, and increased risk of fracture, while excess of it results in hypercalcemia. So, to clear all our doubts about this super nutrient, today MahaFP has arranged a panel discussion with starwards in this field. But first of all, I welcome our MahaFP President, Dr. Hemant Gangolia, sir, to give his blessings. Over to you, sir.
Thank you, Dr. Neha. Good evening, each and everyone, respected dignitaries on the dais. Today's moderator, Dr. Tushar sir, and the faculty, Dr. Hari sir, Dr. Sandhya madam, Dr. Prashant sir, as well as state convener, Dr. Jay Bhandarkar, my secretary, Dr. Amol Pawar. I also see our Dr. Jayan Joshi sir from Pune who has joined, as well as our Women Committee Chairman, Dr. Renu Boralkar, as well as Dr. Chitra Kulkarni and Dr. Neha. Welcome to this session. And on behalf of MahaAP, we thank Catchet Pharma to support this academic event. And this is the third in the row, the use of Big C. I do not know what does Big C means. Probably I feel it is a use of it from pediatric to geriatrics, and so probably it is a use or misuse that I do not know. Probably it will be clarified. This all the esteemed faculty endocrinologists here, and let's see how we can use this Big C in our day-to-day practice. And I'm sure it will be an enlightening session. And also I welcome MahaIP YouTube channel viewers for this session, and wish each one a happy learning all about Big C. Thank you, madam.
Thank you, sir. Today we have with us Dr. Jayan Joshi, sir. He is senior pediatrician as well as guest of honor today. He is from Pune. He was past TV member of Central IIT. Welcome, sir. Kindly unmute and give us blessings.
Yeah, thank you very much for inviting me over. Thank you, Dr. Hemant, Dr. Amol. Hello to Dr. Jay and all esteemed faculties. I think I must appreciate the initiative taken by MahaAP in this regard to enlighten about very common issues in our practice, which we have faced with regularly, and we need to know more about it. I think one of the most important pressing issue is about calcium. All of us inadvertently write calcium to all the babies. We really don't know what are the real requirements, how far it is necessary. Are we loading the babies with calcium and vitamin D? And I think we need to know a lot deeper into it, because we have experts with us who are endocrinologists and an expert person like Dr. Tushar, who is going to moderate the session. So I am very sure that this will be a very useful session, and it will be an enlightening one for all the delegates attending. And I am really looking forward to listening to it. Once again, thank you very much for inviting me over. And it's a very, very important initiative. And I must appreciate Dr. Hemant, Dr. Amol, Dr. Jay Bhandarkar, and the entire team of MahaAP who is doing this activity on a regular basis. Thank you very much.
Thank you, Jain sir, for your blessings. Today for the panel discussion about uses of Big C, calcium in children, we have with us three eminent experts of pediatric endocrinology. Dr. Hari Mantangni, he has done his fellowship in pediatric endocrinology at Alter Hey Children's Hospital, Liverpool, England, United Kingdom, awarded by the European Society of Pediatric Endocrinology. At present, sir is practicing as pediatric endocrinologist in Nagpur. We have with us Dr. Sandhya Kundakarni, consultant pediatric endocrinologist at Manik Hospital, Aurangabad. She is also secretary, Aurangabad Academy of Pediatrics. And we have with us Dr. Prashant Patil, sir. He has done ESP clinical fellowship from UK. He has 12 peer-reviewed publications, including international as well as national, numerous presentations in national and international conferences, author of chapter Metabolic Consequences of Obesity in Adolescent. At current, he is consultant pediatric endocrinologist and diabetologist at Apollo Hospital, Navi Mumbai, Jaslok Hospital, Mumbai, SRCC NH Hospital, Haji Ali, Mumbai. And the discussion will be moderated by Dr. Tushar Godbole, sir. He is pediatric and adolescent endocrinologist, and he is director of Harmony Health Hub, Nasik. Now I hand over the mic to Dr. Tushar Godbole, sir, for the further proceeding.
Thank you so much, Dr. Neha. And first of all, let me congratulate the team MahaMP led by Dr. Gangulia sir, Dr. Amol sir, and our coordinator, Dr. Jay Bhandarkar, for providing this platform. And it has been going on. We have been meeting at this academic activity very frequently, and I see all three of them attending every academic meet. So that's their level of enthusiasm and energy. फक्त पहिल्या कार्यक्रमाला नाही, सगळ्या कार्यक्रमांना ते हजर असतात पहिल्यापासून शेवटपर्यंत. सो थँक्यू सो मच. जयंत सर, तुमचं पण स्वागत. So in next probably 40 minutes or so, we are going to talk about various aspects of calcium in children, and we have three eminent speakers from Maharashtra. So I hope I'm just sharing my slides. Yeah, is it visible?
Not yet. Yeah.
Yes, sir.
Yeah, right. So we are going to discuss about calcium and its role in physiology, various dietary recommendations, hypocalcemia, what are the causes of acute and chronic hypocalcemia, what is the treatment of hypocalcemia, what are various pharmacological preparations available across the age groups, including the neonates and pediatric age group. And if time permits, we'll touch upon the hypercalcemia that's nowadays very commonly seen. So calcium, all of us know that the basic physiology of calcium is required for all the intracellular pathways, various enzymatic reactions, and various intracellular pathways are indeed controlled and governed by calcium. So the sources of calcium we are going to discuss, but the intestinal absorption of calcium is predominantly dictated by the active vitamin D, that is calcitriol. So calcium absorption happens through intestines. If the absorption is less or the availability is less, then the bone calcium, that's the depot of calcium that is resorbed using the PTH hormone. So PTH hormone is kind of a buffer hormone that draws calcium out of bone and keeps the serum calcium levels well within the range. At the same time, as the calcium levels go down, you also have the PTH acting upon the renal tubules, thereby reducing the calcium excretion and facilitating the phosphorus excretion, thereby maintaining the serum calcium levels. And of course, calcium can never be looked at in isolation. You always, all the time, have to take into consideration the role of vitamin D, because it's often said and it's often documented that if you have a normal vitamin D level, then subnormal calcium intakes can also be taken care of by increasing the absorption. But if you have deficiency, a coexisting deficiency of vitamin D as well as calcium, then the skeletal effects like rickets will be visible. So if we talk about the adult calcium metabolism, a healthy diet is supposed to yield an adult of 1000 milligrams of calcium that is present in the diet. Out of that, around 350 milligrams is absorbed, and 150 milligrams is again secreted through various enzymes and also shedded through the cells. 500 milligrams of calcium is recycled every day in and out of the bones, and 200 milligrams of calcium is excreted through urine. And out of this 1000 milligram that is consumed, only 200 milligram is ultimately assimilated in the bones, and that is excreted in the urine. So in adults, the bone mass is supposed to remain constant. So 1000 is consumed, 200 is absorbed, and 200 is excreted through urine, because adults are not supposed to grow. Their bone mass is already at its peak. Pediatric age group, on the other hand, you can see this dynamics is changing because of the bone accretion or the calcium accretion in the bones. So there has to be a positive balance. So for example, a typical infant, when he consumes or she consumes 210 milligrams of calcium, out of that 70%, that is around 150, will be absorbed. And out of that, actually 93 milligrams is the daily addition to your bone pool when you consume around 200 milligrams. So look at the efficiency of the human body or intestines of the newborns and small toddlers, that they efficiently absorb the calcium. Almost 70% of the calcium that is available in the diet is absorbed in infants, as against in children or toddlers, the absorption rates go down. A typical toddler of around 3 or 4 year old or 5-year-old is supposed to consume around 500 milligrams of calcium. 40% of that is absorbed and it enters the serum, and 140 milligrams, that is around 60% of what is absorbed, actually goes in the bones. So this is the positive net balance that is required for pediatric age group. And if you don't meet these needs through your diet, then the bone mass and the bone development will get affected. So this, we are just talking about calcium. So what are the dietary requirements of calcium? And to answer this, I'm going to ask my dear friend, Dr. Hari. Dr. Hari, would you like to comment on what are the dietary requirements? What is the RDA for calcium in infants and children?
Yeah, thank you, Tushar. The RDA, or Recommended Daily Allowance, has been recently published in 2017 in the Indian Academy of Pediatric Guidelines, and they are different for different ages. Like in premature neonates, to prevent calcium deficiency and development of rickets, it is recommended to doses 150 to 220 milligram per kg per day. And for treatment, the recommended dose is 175 to 200 milligram per kg per day. However, the tolerable upper limit is 1000 milligram per day. So one has to actually see that even if you are giving 150 to 220 milligram per kg per day, it should not go beyond, and which in premature neonates, it won't go beyond it, because a weight of 4.5 kilos is required to cross 1000 milligram. Now in neonates, 200 milligram per day is required for the efficiency, and 500 milligram per day is required for the treatment. From 1 to 12 months, that is the infancy, the recommended dose is 250 to 500 milligram per day for prevention, and same 500 milligram per kg, 500 milligram per day for treatment. From years 1 to 18, there is only single range is there, 600 to 800 milligram per day, both for prevention and treatment. However, whenever we see the ICMR, when I see the ICMR guidelines for RDA, they are given three figures. One is 500, other is 600 and 800. So less than 1 year, they have recommended 500 milligram per day. From 1 year to 10 years, they have recommended a dose of 600 milligram per day recommended allowance. And after 10 years, the recommended allowance is 800. So 500, 600 and 800. So these are the two recommendations of RDA, of dietary requirements of calcium.
Yeah.
And
So
adults,
Yes.
after 18 years?
Yeah, 800 to 1200 milligrams.
Sir, actually, we'll discuss that in a while. So before that, we should talk about the adolescents first. And Dr. Sandhya, would you like to comment on the adolescents? Ma'am, you are on mute.
Yeah. Am I audible now?
Yeah.
Yeah. As we all know, adolescence is the challenging period of any child's life, and there is a maximum bone accrual which is happening during the pubertal age. So the requirement of calcium, particularly during this age, is highest. Due to the hormonal changes, there is maximum mineralization of the bones during this age. Maximum muscle development also occurs at the same age, that is pubertal age. So to prevent the further osteopenia during adulthood or during geriatric age, this is like the calcium banking we can do at pubertal age. So it is the maximum requirement of calcium at this age. So according to ICMR, here is the comparison data. According to ICMR, as Dr. Hari rightly said, the dietary allowances 800 milligram per day, and for females also and males also, it is equally the same, but at times it can go as high as 1000 to 200 milligrams per day. Actually, the dietary allowance should be made up from diet itself, like the low fat milk, or maybe green leafy vegetables, or soya, or ragi, or any milk products. These are the daily products, but the child or at pubertal age can consume. But overall, worldwide, it is observed that hardly there is any part of the world that their dietary requirement is fulfilled by only diet. So according to the child status, whether he is fully active, whether he is of the appropriate weight, what is his screen time, what is his mobility, according to that calculation we have to supplement calcium many a times. Particularly the child, if child is on anti-epileptic drug, child is on special treatments, child is immobilized, these are the high risk states, and that time even in normal children also, it is very rarely fulfilled by diet. So we have to supplement the calcium.
Yeah, I entirely agree. Almost 50% of the am I audible?
Yeah.
Yes.
Yeah. So almost 50% of the adult bone mass is achieved during the adolescence. So Dr. Hemant sir, you were asking about the adult recommendations. So these are the adult recommendations, and this comes from ICMR 2020 document. So they have recently made the recommendation from 600. They have again made to 1000 milligram per day. So this is just a couple of years ago that they have done. So this comes from the ICMR 2020. So now it's 1000 milligram per day, both for adult men and non-pregnant adult females. If you look at the phosphorus recommendations, it is 1:1 for all age groups except infants. And for infants, you need 1.5 times the value that is recommended for calcium for infants. So infants need more phosphorus, but beyond that, the recommendation is 1:1. So moving ahead, Dr. Prashant, would you like to tell us more about the milk as a source of calcium? Because often it's harped upon us that our children don't drink milk. So what is your take on that? How much calcium will they get from milk?
Milk is, as we know, is considered to be a complete source of nutrient, and predominantly the calcium. So roughly speaking, 1 ml of milk gives you a 1 mg of elemental calcium, considering the dilution and undilution. Also, the calcium content may vary depending upon the percentage of fat or a defatted milk. Suppose if it is a regular milk, then a 250 ml, that is 1 cup of milk, will give you 285 milligrams of elemental calcium. Whereas in a reduced fat or a defatted milk, the content of calcium goes as high up to 340 milligram in that 250 ml of milk. But also, if you see, the content of calcium in yogurt is even more. Like only 200 grams of regular yogurt can give you around 340 to 400 milligrams of elemental calcium. The only problem during the first 6 months or 1 year is that cow milk contains higher load of phosphorus. So we have to be mindful, as we generally advocate that up to 6 months, the breast milk has to be advocated and the cow milk should not be given, because content of phosphorus is almost 6 to 7 times more as compared to the breast milk. Normal breast milk will contain almost 12 to 14 milligrams of phosphorus, whereas a a formula milk will contain as high as 96 milligrams of phosphorus. So whenever we are dealing with, especially for 6 months or 12 months, we have to be careful about this calcium and phosphorus imbalance. Otherwise, roughly you can say 1 ml is equal to 1 mg of elemental calcium.
Yeah, and I was surprised to read the ICMR recommendation that a child or a toddler is supposed to consume 500 ml of milk per day to fulfill the calcium intake. I was really taken aback. And when I used to recommend milk to all the children that used to come to growth clinic, my teacher, Professor Vijayalakshmi Bhatia, used to tell Tushar, not everybody is privileged enough to have cow or buffalo at their doorstep. There are so many people in villages, they can't afford milk, and they can have milk only when their cows or buffaloes are they have delivered and they're still lactating. Rest of the times, majority of the poor class do not have access to milk. So Dr. Hari, back to you. What would be the sources of calcium if we have a patient who does not afford or do not have access to calcium?
So there are many non-milk sources of calcium. So there is nothing to get disheartened. We can have all these things, including cabbage, broccoli, spinach, carrot, tomatoes, with varying degrees of calcium in milligram and 100 milligram. So the exotic vegetables like kale, collard, or turnip might not be available easily. But yes, we have got soybean, which is a good source of calcium. Similarly, fruits like tangerines, blackcurrant, if we don't have, oranges are there to help with the consumption of calcium. Similarly, we have very low calcium in apple, apricots, and peach. But yeah, they give only 4 to 8 milligram per 100 gram consumed. So in the descending order, I think cabbage, broccoli, spinach are very important sources, and soybean, they are very important sources. But again, any vegetable, green leafy vegetable consumed will give you a good amount of calcium in it. And if one is thinking of a non-vegetarian diet, then fish, particularly salmon and fish, will have highest amount of calcium, that is 283 per 100 gram consumed. In addition to it, chicken and egg will have also calcium, but the calcium content in egg is higher. It is around 50 milligram per 100 gram consumed, and chicken has got a very low source of calcium. As against almonds, again, a very costly thing for a poor person to consume, but every 100 gram consumed will give almost 250 to 350 milligram of calcium. Apart from this, any cereal consumed or mixed grains, they give a regular calcium around 50 grams per 100 gram. So if we can just remember this figure of 50 grams per 100 gram, that is what an egg will give, or cereals and regular diet will give. But green leafy vegetables, yes, definitely, along with fruits, they are really good source of calcium.
So I often, thank you. One, underutilized source of calcium is the cabbage leaves. म्हणजे फ्लावर आणि कोबी जो असतो त्याची जी पानं आपण तो काढून देतो ना भाजीवाला. So we ask them to just give the broccoli or the cabbage or the cauliflower. But those green म्हणजे फुलगोबी के पत्ते या फ्लावर के पत्ते ज्याला आपण पानं म्हणतो ती बाहेरच्या पानातच जास्त कॅल्शियम आहे. And we ask them to just remove and throw. And those goats and buffaloes and cows are eating at the roadside. That has all the calcium. One more underutilized source of calcium is calocasia leaves, alu. Arvi ke patte, aluchi pana is one again underutilized source of calcium. And I think you already mentioned about the ragi, right? Nagli is also a rich source of calcium. So Dr. Sandhya was talking about the prevalence of dietary deficiency. So these are various studies from Dr. Khadilkar and group 2017. 75% of urban children were having their calcium intakes below the recommended daily allowance. data from Konkan, Western Maharashtra, 77% of adolescent girls were having hypocalcemia in their study by Dr. S. Patil. Again, Dr. Khadilkar and group from 2007, they have reported low calcium intakes in adolescent girls that are associated with bone pains and genu valgum. And this one particular study comes from Lucknow in 2009, where they have shown very, very low calcium intakes to the tune of 250 milligrams per day in adolescent girls, that is associated with low bone mineral density and bone pains. So it's a sorry state, particularly in adolescent girls from the rural India, that they have the maximum problem of low dietary calcium. So we are going through two cases now. First case is a newborn 3-day-old male child. He's born of a non-consanguineous marriage. The mother is diabetic. She's an IT professional, so probably has not seen the day of the light or the sunlight for last so many months. The baby is 3.5 kilos, slightly on the heavier side. The baby is admitted with staring look, lip smacking, and jitteriness. And the serum calcium on admission was 7.2 mg/cent. So is this hypocalcemia? Is the cause for these seizures or jitteriness calcium? So Dr. Sandhya madam, would you like to define what is hypocalcemia and how does it differ between newborn babies and children? Dr. Sandhya ma'am. She seems to be there in the meeting. Okay, so I'll come back to her maybe a little later. So we'll talk about the common causes of hypocalcemia in newborn babies. So Dr. Prashant, would you like to elaborate the common causes? Of course, in the particular case that I have already mentioned, that the lady is an IT professional, but what in your practice or what is the literature that says what are the causes of hypocalcemia?
So roughly hypocalcemia in neonates is divided into two types. So one is early neonatal hypocalcemia, which is seen in up to 48 hours to 72 hours of life. Whereas the hypocalcemia which occurs later than 72 hours of life is known as late onset hypocalcemia. So the commonest cause for hypocalcemia, especially during early neonatal age group, is prematurity, infant of diabetic mother, the IUGR, birth asphyxia, very rarely maternal intake of anticonvulsant, and sometimes iatrogenic because of the use of blood products. Now, each cause has precisely the prematurity is because of inadequate storage of the calcium, especially during the third trimester is the common cause. As you have covered the case of infant of diabetic mother, which is a peculiar scenario. So what happens in diabetic mother that once the child is born to a GDM mother, they have a state of hypoparathyroidism, which is a transient in nature. So because of that, they may have a hypocalcemia. Secondly, they also have a hypomagnesemia associated with it. So that is the common cause of hypocalcemia. The birth asphyxia, which is again a commonest cause for hypocalcemia. Precisely in birth asphyxia, there's an excessive state of catabolism, which leads to a lot of hyperphosphatemia. Also in birth asphyxia, the feeding is relatively delayed. So that the inadequate intake is one of the pathologies. Also, since they have metabolic acidosis, often been subjected to bicarbonate use, a bicarbonate infusion. So that is also one of the causes of hypocalcemia. When we talk about the late onset hypocalcemia, which is occurring after the 72 hours of life, it's predominantly related to phosphate load. As I've covered that early initiation, especially as they start before 6 months of life, milk or a formula milk, which often has very high phosphorus load, that is a commonest cause of hypocalcemia. Vitamin D deficiency in our scenario is again very common. Hypomagnesemia, maternal vitamin D deficiency, these are the commonest cause which we come across during our in our clinical practice. very rarely we see a cases of hypoparathyroidism or PTH resistance. Hypoparathyroidism could be primary, or there's some syndromes like DiGeorge syndrome, Catch-22 syndrome, which is associated with congenital heart defect and hypoparathyroidism. Some of the metabolic syndromes or mitochondrial disorders like Kaine-Caffey or Kern-Sayre syndrome, which is associated with ophthalmoplegia. These are relatively rare causes of hypocalcemia. And similarly, like early onset of hypocalcemia, iatrogenic uses of citrated blood products, because those children who are often sick, they receive multiple transfusion. So because of the citrate, maybe bicarbonate, which is used for acidosis or metabolic acidosis correction, loop diuretic, phototherapy can also be a cause of hypocalcemia. So roughly speaking, these are the commonest causes of hypocalcemia.
And in your experience, what percentage of these babies have purely vitamin D deficiency?
Almost 60 to 80% we generally see as a maternal vitamin D deficiency and vitamin D deficiency in children, especially the late onset. And
whenever
most
we
of the
have
times
this,
it is prematurity. Sorry.
Yeah, so I was saying the same thing, that it's often, at our discussions, it's always mentioned in our practice, we see a lot of vitamin D deficiency related neonatal hypocalcemia, but in the literature, it's not mentioned as one of the common causes. Yeah. So I think we should all compile and, report this. It's an important cause that we often fail to report. Sorry. So Dr. Sandhya ma'am has joined. So Sandhya ma'am, would you like to elaborate more on the definitions of hypocalcemia, in particular newborns and children? How do they differ? You're on mute, ma'am. I think there seems to be some internet problem with Dr. Sandhya ma'am. Yeah. So the definitions
she has rejoined, but
okay. So the definitions vary between the age groups, and newborns are generally having lower calcium values. So the newborns that are born above 1500 grams, when the total calcium is below 7.5 to 8 milligram percent, that's the time we call it as hypocalcemia. Sandhya ma'am, are you there? For children, for newborn babies that are born extremely low birth weight, the cutoffs are even lesser. And there are various mechanisms, various reasons behind this. But, the smaller the baby, the lower the cutoff. And as the children grow in their age, the cutoffs will go, on the higher side. For children between 1 to 5 years, generally the normal range is anywhere between 9.4 to 10.8. And for adults or adolescents, the range is between 8.8 to 10.2. All of us are aware of the corrected calcium that we calculate for children with liver disorders or nephrotic syndrome children, where the total calcium seems to be low, but that's because of the carrier molecule that is lost through urine. And there you go by the corrected calcium and don't just rely on the total calcium value. So moving ahead, we now discuss the treatment part of hypocalcemia in newborn babies. So Dr. Hari, would you like to talk about the treatment of hypocalcemia in newborn babies?
Yeah, so when treating hypocalcemia in neonates, we find two varieties. One is asymptomatic hypocalcemia, in which if the total calcium is less than 7, then only we treat them even if they are asymptomatic. And we have to remember that 1 ml of calcium will roughly give 9 milligram of elemental calcium, that is 10% calcium gluconate. So for asymptomatic cases, the recommended dose is 8 ml per kg per day of 10% calcium gluconate, that is 80 milligram per kg per day over 48 hours it has to be given. And for 2 days, after 2 days, the dose is halved to 40 milligram per kg per day. And then this thing is stopped because we are talking about early onset neonatal hypocalcemia. If in symptomatic cases, we have to quickly bring the calcium towards slightly on the normal side just to avoid symptoms. So a bolus dose of 2 ml per kg of calcium gluconate is required, which is 1:1 diluted with 5% dextrose. And it is given over a period of 10 to 20 minutes under cardiac monitoring. This bolus should be followed by a continuous infusion of same 80 milligram per kg per day over a period of 48 hours. And we have to document normal calcium at 48 hours. If the calcium has come to normal, then we taper the dose to 40 milligram per kg per day for one more day and then stop. If we are having a neonate which is having symptoms, that is late onset, so treatment is continued up to 72 hours. And prophylactically, people say there have been some recommendation that if there is prematurity, gestational age is less than 32 weeks, like Prashant mentioned, sick baby, or in the case it was mentioned that it is a newborn of IDM mother. And if the child is neonate has suffered severe asphyxia, they are more likely to have hypocalcemia. And some literature has mentioned prophylactic calcium which has to be given in such kids, that is 40 milligram per kg per day, that is 4 ml per kg per day of calcium gluconate. Oral should be used if it is tolerating, but one has to be very cautious when using oral dose in sick newborn, if the newborn is sick, because it may precipitate necrotizing enterocolitis in them. The treatment is continued for 72 hours, and continuous infusion over a period of 24 hours is better than giving 6-hourly boluses. And in symptomatic babies, 48 hours in continuous infusion is given. So if it is not getting corrected by 72 hours, we have to investigate for other causes of late hypocalcemia, which Prashant has already mentioned.
Yes. And starting oral calcium at the earliest, because you can never match the calcium intake through oral route with the IV. IV will always fail, but the oral calcium intake you can go very high very quickly.
Yeah,
very safely.
I would like to mention a few word of caution here. One is please check that it does not get extravasated because it leads to a tissue necrosis. If we are giving IV boluses, that has to be given very slowly and under cardiac monitoring. Third thing is, if we are giving by umbilical venous catheter, then we have to check, confirm that the tip is in the vena cava rather than the portal vein, because it can lead to hepatic necrosis, and it should never be given through umbilical artery. These are the important word of caution while giving IV calcium gluconate to a newborn.
Sure. So a word on late
neonatal hypocalcemia. The treatment is specific to the etiology, and in certain diseases may require the child may require treatment therapy for a long time. The most important cause, that is hypomagnesemia, when hypocalcemia does not respond to IV calcium therapy, it is usually due to hypomagnesemia, and it may present as early or late neonatal hypocalcemia. The treatment is simple. It includes intramuscular MgSO4 50%, 0.2 ml per kg. So 2 doses are required, deep IM. This has to be followed by a maintenance dose of 0.2 ml per kg per day of same 50% of Maxel per oral for 3 more days. If there is a high phosphate load, these infants can be diagnosed by the biochemistry pointing towards hyperphosphatemia with near normal calcium levels. Exclusive breastfeeding should be encouraged in such neonates, and top feeding with cow's milk should be discontinued if it is there. And about phosphate binding gels, they should be avoided as far as possible. Now, if the neonate is diagnosed to have hypoparathyroidism. They will be next, yeah. The biochemistry will point towards the cause. They will be having hyperphosphatemia along with hypocalcemia and a normal renal function. These kids usually, this neonates or this babies usually require calcium and calcitriol. Calcium in the tune of 50 milligram per kg per day in 3 divided doses, and similar calcitriol 0.5 to 1 microgram per day. This is the therapy may be stopped if the hypocalcemia is secondary to maternal hyperparathyroidism. In vitamin D deficiency states, you have to treat with either calcitriol 30 to 60 nanogram per kg per day, or we can give directly vitamin D of 1000 to 2000 international unit per day. These babies will have a biochemistry typically showing hypocalcemia along with hypophosphatemia and high PTH levels. So we have to ascertain the cause of hypocalcemia and give treatment accordingly.
So the hypophosphatemia, it's often reported that it may not be always present in the neonates with vitamin D deficiency. People have seen vitamin D deficiency with normal phosphorus as well, especially in the newborn babies.
Yeah, and again, a word of caution here before interpreting phosphate reports. We have to see age-wise phosphate level from neonatal age group to early childhood to late childhood. The normal serum level of phosphate decreases from around 5 to 6 milligram per deciliter to around 2 to 3 milligram per deciliter in late adolescence.
So coming to second case, she's a 9-year-old female has noticed generalized weakness and muscle aches, has been homebound over last 2 years due to lockdown, has developed one episode of carpopedal spasm yesterday, and she has her growth and development that is age appropriate. The serum calcium is 8.2. So what is it? Hypocalcemia, and what is the cause of hypocalcemia? So Dr. Sandhya, would you like to quickly mention about the definitions of hypocalcemia?
Yes. Sorry for the interruption, Tushar. My net was not properly connected, and thanks for taking up my slide of definition of hypocalcemia. So here is the case of 9 years female. So we are now dealing with the childhood hypocalcemia, and according to definition less than 8.4, so it is surely the hypocalcemia. And so my question is, what are the causes of particularly acute hypocalcemia in children? These are surely different from the chronic or subacute causes of hypocalcemia. And these are the situations where we have to immediately treat the child with intravenous hypocalcemia. So I had taken first event of a subacute presentation of hypocalcemia. As Dr. Hari mentioned, which are the causes of hypocalcemia, or Dr. Prashant also discussed, primary hypoparathyroidism or acquired hypoparathyroidism. Primary hypoparathyroidism, as we know, it can be due to CASR stimulating mutation, or it can be a part of multiple endocrinopathy or polyglandular syndrome type 1, or it can be a part of IPEX syndrome also, or it can be a acquired hypoparathyroidism, what we see in the children with thalassemia, where we see hemochromatosis or Wilson's disease, or maybe granulomatous diseases like sarcoidosis. These are, or maybe traumatic etiology, or maybe radiation hazards when we treat hyperthyroidism with radionuclide iodine. Or maybe during surgery for thyroid, we can have acquired hypoparathyroidism, or it can be an autoimmune, isolated, or part of polyendocrinopathy, or late onset Dijor syndrome. So these are some causes of subacute presentation of hypocalcemia. But if we see for particularly acute hypocalcemia, we can have a situation when there is severe vitamin D deficiency, and if we treat the children with even very small amount of vitamin D, it has been calcium has been vigorously taken up by the bones for rapid mineralization, and there can be situation of acute hypoglycemia, severe hypocalcemia. Or severe vitamin D deficiency also can cause acute hypocalcemia. After parathyroidectomy, during surgery in the OT only, we can face severe acute hypocalcemia, surgery for primary hyperparathyroidism. So we have to be ready with IV calcium gluconate. Excessive magnesium, if we treat for magnesium deficiency, or maybe sometimes treatment of any other etiology or treatment of even hypocalcemia, if the dose of magnesium is exceeded, then due to excess magnesium, there is inability to secrete PTH, and that can cause acute severe hypocalcemia. We treat many a times children of maybe osteogenesis imperfecta or other diseases with bisphosphonate treatment, and this bisphosphonate causes increased osteoclastic activity and increased calcium deposition in the bones. So during this also we have to be very cautious, and we usually monitor serum calcium, serum creatinine. This can cause acute hypocalcemia. Intravenous administration of phosphates or maybe phosphate enemas, or maybe high dose of oral laxatives which contain phosphates, these also can cause acute severe hypocalcemia, because usually body tries to maintain phosphate and calcium ratio within normal limit, that is usually 30 is the ratio. So anything which causes high phosphate load can cause acute and severe hypocalcemia. Many a times in solid tumors, or when tumor lysis occurs during the initial phase of treatment, or anything which can cause rhabdomyolysis can cause increased phosphate level, acute increased hyperphosphatemia, and which can lead to acute hypocalcemia. In ARF or CRF, in acute renal failure or chronic renal failure, many times we can face acute hypocalcemia. Multiple blood transfusions or plasmapheresis adds, these are the citrate transfusions usually we give, and calcium gets deposited with citrate, so there can be acute hypocalcemia. In cases of acute pancreatitis, as there is increased level of lipase and there is release of fatty acids, and these fatty acids usually get combined with calcium, and there are the complexes of calcium with fatty acids which get deposited, and this can also cause severe acute hypocalcemia. Even in acute severe illness, any type of illness which is critical needing ICU admission, we can see hypocalcemia. There are many reasons. There can be a functional hypoparathyroidism, or there can be vitamin D deficiency, there can be mobilization, so or there can be cytokine release which also can hamper with the PTH secretion. So these are the multiple etiologies which can cause acute hypocalcemia in particularly children, not in neonates but in children.
There is one more peculiar presentation that all of us have seen, that typically teenage boys or girls, just before their examinations, or if they have somebody has scolded them, if they are under stress, they have that carpopedal spasm, and when the pediatrician documents serum calcium level, it is normal. So would you like to enlighten what is going on?
I haven't faced such situations.
So that hyperventilation related
yeah, that stress can cause hyperventilation, and that can cause alkalosis, which can lead to that can happen. Yes. Yes.
Yeah,
or even any illness which can cause hyperventilation, by that way can cause hypocalcemia.
Okay. Absolutely. So Dr. Prashant, Dr. Hari has already mentioned the treatment of hypocalcemia in newborn babies. So what more can we do, or what else can we do for children with acute hypocalcemia beyond the age group of neonates? And also please tell us what is the role of active vitamin D in such cases.
So in terms of treating acute symptomatic hypocalcemia, it is more or less same as we treat in neonate, especially the bolus component remains the same. We generally prefer the calcium gluconate 10% solution, though it contains relatively less milligrams of elemental calcium, calcium chloride is generally avoided in pediatric age group. At the same time, once we treat them for initial bolus dose, the infusion of calcium is relatively better as compared to the boluses given 6 to 8 early, as Hari has mentioned. But if you find it difficult in peripheral setup, we can give slow bolus every 6 to 8 early up to 48 hours. And as Hari has mentioned, we have to give it very slowly under the heart rate monitoring. However, the treatment of asymptomatic patient with hypocalcemia remains controversial. Once we treat the acute hypocalcemia, especially during the pediatric age group, we have to find out the cause. Is there any underlying severe etiology which is causing the hypocalcemia? We have to rule out the hypoparathyroidism. At the same time, we have to rule out there is a document that the renal functions is absolutely normal. To answer the last question, what is the role of active vitamin D? So only the role of calcitriol or active form of vitamin D is there in secondary hyperparathyroidism with chronic chronic kidney disease stage 2 to stage 5. In case it can be used as an adjunct to calcium supplementation if there is a seizure or documented tetany. In that case only you should give the calcitriol, otherwise there is no role. Often a pediatrician have been told to give certain syrups like Gemcal, which has calcitriol, but in cases of asymptomatic hypocalcemia, I think one should not give the calcitriol. Also during early pediatric age group from 1 to 2 years, especially during the infancy, there is inherent resistance to the calcitriol. So it may or may not work. So calcitriol, though often recommended as a wonder drug, I really doubt whether it really helps if the underlying etiology is not malabsorption or is not a hypoparathyroidism.
Okay, but suppose in acute stage, if you have a problem with the securing IV lines, so as a tide over, can you use calcitriol for some time?
If it is associated with tetany or seizure, yes, we can give. Yes.
So in that case, how do we administer that? Because it's generally a capsule. So
what we generally tell them is to take 1 cc syringe, the same syringe which you use for ABG or VBG, aspirated because it is associated, it is there in a liquid formulation, and give it through oral route.
Perfect. Thank you. So coming to chronic hypocalcemia, and in chronic hypocalcemia, all the endocrine causes would be coming. So especially in pediatric age group, you have hypoparathyroidism or pseudo hypoparathyroidism, where the PTH hormone is not getting produced or it's not acting on its receptor. It becomes a common cause of chronic hypocalcemia. We already have seen renal failure that can come as an acute or chronic hypocalcemia. There is something called as hypercalciuric hypocalcemia that comes to us with a chronic hypocalcemia, and there is a specific set of rickets where the action of vitamin D, the active vitamin D, is either not getting produced or not acting on its receptor. So Dr. Hari, now moving on to the chronic part of hypocalcemia, I know that it's a specialist job, but you are dealing with these cases. So how do you treat the chronic hypocalcemia?
So yes, most of my treatment part will be it will be a repetition from what we discussed in the neonatal section, but I would like everyone to note down the investigation which are to be done before initiation of therapy, because once the therapy is initiated, it makes us very difficult, make it difficult for us to actually interpret the reports. So a complete blood count, serum concentration of total and ionic calcium, magnesium, phosphate, creatinine, intact PTH, 25 hydroxyvitamin D, and a sample which can be later processed for 125 dihydroxyvitamin D levels. Along with the urinary calcium and create concentration in a spot urine is a very important sample. Whenever one, it is like a critical sample what we collect in hypoglycemia, all the metabolic things which are happening during the hypoglycemia. Similarly, at the time of hypocalcemia, what the chemistry suggests will point towards the likely etiology, because I have seen so many reports now with only calcium and alkaline phosphatase, and no phosphate was measured in that, and they are like chronically treated for vitamin D deficiency and later on turn out to be hypophosphatemic rickets. So low PTH usually suggests an impaired PTH secretion. However, a high PTH concentration is present in vitamin D deficiency or insensitivity. So it is vitamin D deficiency disorder, which is very common. A high PTH also is seen along with hypocalcemia if there is PTH resistance to loss of function mutation in PTH receptor 1, or if there is impaired renal function. If there are low vitamin D levels, signifies decreased stores and rarely a defect in vitamin D25 hydroxylase, and a low calcitriol level. So activated vitamin D, it is inappropriately low in severely compromised renal function, hypoparathyroidism, and deficiency of 1-alpha hydroxylase, which is responsible for conversion of 25 hydroxy vitamin D to 125 dihydroxy vitamin D. An elevated calcitriol value usually suggests, in presence of hypocalcemia, usually suggests towards the diagnosis of vitamin D resistance, though it is a very rare to see such thing. The most important or the most commonly seen disorder is due to vitamin D deficiency insensitivity. So I would just like to show you this hypocalcemia chart. And if we are getting a low serum calcium, urinary calcium, see how important it is. If the urinary calcium is, the normal response should be reduction in urinary calcium. If it is high, it points towards a diagnosis of activating mutations of CASR or primary hypomagnesemia. If the urinary calcium is low, then we look at intact PTH. And if the PTH also is low, then we look at magnesium levels. And if it is low, it is hypomagnesemia. And if it is normal, then the diagnosis is spot on of hypoparathyroidism. On the other limb, we have high parathyroid hormone. We have seen in vitamin D disorders, but that has to be correlated with serum phosphate levels. If the serum phosphate is high with a high creatinine, it points towards a diagnosis of renal failure. And if the creatinine is normal along with high phosphate, then we see we have got so many rare disorders which usually get missed if we don't do a serum phosphate level, like pseudo-hypoparathyroidism, dysharmonogenesis, or PTH resistance syndrome, or excessive phosphate load like increase intake. If the phosphate is low and PTH is high along with hypocalcemia, then it goes towards a limb of vitamin D metabolic defect. If 25 hydroxy vitamin D is low, then it is vitamin D deficiency. If it is normal, then we check for 125 dihydroxy vitamin D in the sample which we have preserved, taken during hypocalcemia. And if the calcitriol level is high, then we diagnose vitamin D resistant rickets. And if it is low, then it points towards the diagnosis of deficiency of 1,5 hydroxylase. So this is just in a nutshell an approach to hypocalcemia. And I hope there are no doubts in this. So what are the treatment goals? What are we thinking when we are treating a child with hypocalcemia? The most important goal is to ameliorate the signs and symptoms of hypocalcemia. So chronic hypo, I'm not talking about the signs and symptoms of acute hypocalcemia, but chronic hypocalcemia. And by maintaining the calcium level close to low normal range. Why we want to keep it at the low normal range? Because we have to prevent iatrogenic development of hypercalcemia and hypercalciuria leading to nephrocalcinosis or renal stones. So recommendation say that the calcium creatinine ratio in urine should be kept less than 0.2. We have to also look at calcium and phosphate level, and the product of calcium phosphate should be kept below 55. The normal body tries to maintain it at around 30, but we are supposed to keep it below 55 because this will prevent the precipitation of calcium and phosphate in extra skeletal sites and can lead to extraskeletal calcification, and will have dire consequences of because we have seen calcium getting deposited at the basal ganglia and caudate nucleus, leading to movement disorder, seizure disorder. So seizure because of hypocalcemia and seizure occurring after treatment is really a different thing. So these are the important goals, and this is how we are going to treat. If it is asymptomatic hypocalcemia, it may not require any acute therapy, but asymptomatic patients, or if the calcium is less than 7.5 milligram per deciliter, they will require IV calcium gluconate, and they should not be given along with bicarbonate phosphate because it usually precipitates. Extravasation should be avoided, and after stabilization we have to ascertain the cause and switch to the definitive therapy of oral, shifting this patient to oral calcium and calcitriol if it is because of hypoparathyroidism or pseudo hypoparathyroidism. The dose for calcitriol is 20 to 60 nanogram per kg per day, given every 12 hourly, and calcium of 30 to 75 milligram per kg per day in 4 divided doses, or it can be given in 3 divided doses also. A recombinant human PTH use has been suggested, and it is not recommended for children, but one can use in late adolescent period if they are having intractable or very difficult to treat from calcium and calcitriol, particularly poor compliance. If it is vitamin D deficiency, the recommendation say to treat the deficiency, we have to give 60,000 IU per week for 6 weeks, or a dose of 300 to 600 IU per day can be given to treat vitamin D deficiency. The most important thing is to ascertain the cause and then acting on it, whether we are supposed to give vitamin D, that is simple, in 3,000 to 6,000 IU, or we are supposed to give calcitriol, or we are supposed to give only calcium. So the most important thing is to ascertain the cause.
A quick comment that vitamin D deficiency, the daily dose in the latest recommendation of 2021 has been made now. They have made it really simple: 2,000 units per day for infants and 3,000 units per day for children. So now that's a small, recent development. So while monitoring, Dr. Hari, how would you like to monitor these patients who are on chronic hypocalcemia management?
So once we have started them on therapy, we have to monitor, and every time when the patient comes, we have to check for serum and as well as urine levels of calcium and creatinine to find the urine calcium create ratio, and check whether the calcium are at the lower limits of normal. This is usually done 3 to 4 monthly, and treatment is modified to maintain a low calcium urine calcium to create ratio in urine to less than 0.2. We have to avoid iatrogenic hypercalcemia, hypercalciuria, nephrocalcinosis, and renal insufficiency. And for nephrocalcinosis, a 6 monthly or a yearly ultrasonogram has been suggested to monitor for development of nephrocalcinosis and renal stones. Okay. So this is how a typical case of prolonged hypocalcemia is to be monitored.
Thank you. So, Dr. Prashant, there was a mention of PTH in the flowchart that Dr. Hari mentioned. So, would you like to comment on that PTH, Dr. Prashant?
You are asking regarding the sample?
Yeah.
So PTH is heat labile hormone. So often when we collect the sample for PTH, we have to send it to the lab immediately and ask them to process within 30 minutes, ideally, if not late, then within 60 minutes, because otherwise we may find false low values in that case. So serum PTH, intact PTH has to be processed immediately to have a normal or exact reports of PTH levels.
Thank you. So Dr. Sandhya, this was all about the oral calcium. So now, oral and IV calcium, but now coming to the formulation. So in ICU setups, we generally use the injectable calcium. So what formulations are available, and how do you prepare them? How do you infuse them?
Yes. So far now we have already discussed about the usual treatment of hypocalcemia. acute severe hypocalcemia, we treat with intravascular calcium gluconate. And I think everybody will agree that in every ICU setup, usually what we learn also, we learn with calcium gluconate only. So calcium gluconate is the ampule which is available in every ICU, and which is most of the times, 90% of the times, we take it from our pharmacy and we use calcium gluconate. So calcium gluconate is 10 ml ampule, and it is having 1000 milligram or 1 gram of calcium per 10 ml. So each 1 ml of calcium gluconate is having 100 milligram of calcium, or 1 ml of the calcium gluconate is having elemental calcium of 9.3 milliequivalent per 1 ml. So in neonates and in children, there is some difference in the doses. In neonates, usually we treat below 1 month, 100 to 200 milligram per kg IV is the initial dose, and 100 to 200 milligram per kg every 6 hourly we give the boluses. Or for continuous infusion, we use 17 to 33 milligram per kg per hour. Or in simplified language, we can say 1 to 2 ml per kg is the initial dose, and usually maximum up to 6 to 8 ml per kg per day is the whole requirement, and usually we give the infusion accordingly, or maybe 6 to 8 hourly divided doses. In pediatric, the doses are low. According to per kg calculation, it is 30 to 60 or milligram per kg, or we can say 0.3 to 0.6, or again, if simplified, 0.5 ml per kg is the initial dose, and we can give it every 6 hourly, and we can calculate as 2 ml per kg per day, and we can divide it in infusion dose. In adult, usually they give 1000 to 2000 milligram every 6 hourly. Calcium gluconate is the usually commonly used IV preparation for calcium correction. And as Dr. Hari mentioned in some last discussion, we have to be very careful about giving calcium gluconate. It should not be extravasated. It should be given very slow. The rate of infusion in pediatric population should not exceed maximum up to 1 ml per minute, even in treating acute severe hypocalcemia. And it should not be extravasated, and it should be given very slowly with cardiac monitoring. So this is the most common formulation what we use in ICU setups for correction of hypocalcemia. Another is the combination of calcium gluconate plus calcium lactobionate. Calcium Sandoz is the commonest preparation what we use. Here also each ml contains calcium gluconate 50 milligram plus calcium lactobionate 87.5 milligram. Total elemental calcium is almost equal to calcium gluconate only. It comes around 9, sorry, it is not milligram, it is milli equivalent per ml. It is the elemental calcium. Calcium carbonate IV, it is rarely used. I think calcium carbonate, what we use is usually oral preparation of calcium carbonate. We hardly see IV calcium carbonate giving. Calcium carbonate is the highest calcium content but least bioavailability. So not much preferred. And IV calcium gluconate, Tushar, can you please enlighten, because I haven't used calcium carbonate IV.
I personally have no experience. All of us have used calcium
so
gluconate.
These are the two preparations usually we use in ICU setup.
So while the patient is on infusion, how do you monitor the calcium? That's a common, a confusion amongst the pediatricians, that on one hand they are on an infusion. So how to collect sample while they are on infusion? So how do you do that?
What usually we do in our setup, or what we were taught, that during infusion, it is the fallacious report. You can use from the other extremity. Collection can be done from the other extremity. But ideally, we usually treat the severe acute episode of calcium. We usually taper it to 40 milligram per kg, and then we can collect. Or even if we want to collect, we can collect from the other extremity.
Yeah. So Dr. Prashant, now I'm coming to you, and probably this is the most important, or people want to discuss or hear about the oral preparations of calcium. because every OPD patient that comes to us with ye khata nahi hai, vajan badhta nahi hai, is given a prescription of oral calcium. So what all formulations that are available in Indian market, and is there any comparison, any data that one is better than the other?
So there are almost 5 to 6 calcium salts which is routinely available. The common one which we generally get or generally it's having in our OPD is calcium carbonate. The reason being it is most cheaper and the amount of elemental calcium is maximum in calcium carbonate. Plus, for the pharmaceutical companies to manufacture in bulk, it becomes easier. So all your Calcimax, Caldikind, Calcikind, most of the preparations are calcium carbonate. Calcium acetate contains exclusive, it is only available in tablet form, in tablet phosbine and phosphate, which contains 667 milligram of elemental calcium. But again, it is only available in tablet form. The calcium lactate and calcium lactobionate or glucobionate is available in combination like Calcimax or the Mecalvit or Calciarc that contains roughly around 100 to 200 milligram of elemental calcium. So roughly speaking, although the list is quite big, I would suggest that most of the times we should see that the child is taking calcium carbonate because then it is a cheaper also. Secondly, the absorption is almost 40 to 50%. I haven't got a one-on-one salt absorption data, but whatever literature that I could assess, it says that calcium carbonate is much better and easily available formulation, and that's why it is produced in a lot of quantity, and most of the brands are available in calcium carbonate salt. The other forms, I mean, even I have to Google and find out that list. As you can see, these are the brands which we hardly see in clinical practice. So Calciar, Calcionate, even I have not used.
Any comment, Prashant, on calcium phosphate, especially for infants? What is your take on that?
Correct. So that contains additional phosphorus around 100 to 150 mg, but we have to be careful, especially treating the early hypocalcemia. If it is associated with hypophosphatemia, then only we should use the calcium XP formulation. Otherwise, if it is predominantly late neonatal onset, which is because of the high phosphate load, we should avoid calcium XP and give.
And what about those VLW babies or preterm babies? They have osteopathy of prematurity. So, yeah.
In that we can use this
phosphorus based.
Yes.
Yeah. And beyond infancy, what is the harm in using these products with phosphorus?
If the calcium and phosphorus ratio is not maintained, that is one thing, and it can lead to a hyperphosphatemia.
Yeah. Okay. Anyone wants to add to that? Hari?
Yeah, so the phosphate will actually stimulate the PTH. This PTH will go up and perhaps will delay the healing of rickets, for which purpose we are giving it. So I usually avoid giving phosphate out if beyond infancy, and if it is not a very premature with osteopenia of prematurity and all, then phosphate should be avoided. I think Calcimax is more important than Calcium XP. Yes.
Yeah, I think we should not be discussing the brand names, but yes, calcium alone or calcium carbonate with elemental calcium of around 250 per 5 ml is a better brand than giving it with phosphorus, particularly beyond the period of infancy. There are a few studies from adults.
May I ask one question?
Sure, sir.
Routinely we see it is said that 1:2 this ratio of calcium phosphorus. So definitely we should not use phosphorus. You mean to say that is a take-home message? Only calcium.
Beyond infancy.
Because most of the calcium preparation, they have the phosphorus.
Right.
No, sir. I would come here that most of the preparation, they don't have phosphorus. They have magnesium. And whenever it is associated with phosphorus, it comes with P. So Calcimax P or Mecalvit P. So whenever
or
it
osteocalcium
always comes.
is one brand which has got phosphate.
Yes, the osteocalcium is also has phosphorus.
Yeah, but beyond infancy, it is not recommended because it is going to stimulate the PTH and actually will lead to more bone resorption then. And the calcium phosphate ratio suggested is 1:4. I don't know, Tushar. I think 1:4 is the ratio suggested. Here it is always 1:2.
Yes.
So two things. First is, of course, the neonates and infants have higher phosphate requirements, so you need to supplement them. Beyond infancy, they are on a staple diet that is cereal based, and cereal based diet also has phosphorus, so you need not give additional phosphorus. That's second. And as Hari correctly mentioned, giving additional phosphorus is going to stimulate the PTH, which will defeat the whole purpose. So we don't want to stimulate the PTH. So giving phosphorus additionally is not a good idea beyond infancy. There are a couple of papers that have compared the efficacy of calcium citrate, calcium maleate versus calcium carbonate. And what they have found is the absorption rates of the citrate or maleate are better than carbonate by only a fraction of 20%. So by giving citrate or maleate or the lactate combinations, you achieve 20% better combination. But if you compare the cost to that absorption ratio, carbonates are by far the most cheap available brands, and you could easily adjust for that cost component. So I think carbonate is by far the most common brand, and there is a lot of data available on the efficacy of calcium carbonate in hypocalcemia in children. There are a few more. So this is just a table that I could quickly gather. So this is the percentage of calcium present and what calcium milligram per gram will be delivered. So calcium gluconate, as Dr. Sandhya Madam was telling, it's a very, very big molecule. So it is not advisable to give these big molecules orally. So orally you give a molecule that is small and has maximum percentage of calcium. So calcium carbonate has got the maximum percentage and it's cost effective. These are some other preparations. I'll skip over this.
One more word I would like to mention is whatever we mentioned, the doses and everything is in terms of elemental calcium, not the total calcium, because it is like 500 milligram with a total calcium and elemental calcium of 200 milligram. So that also has to be cautiously taken into consideration.
Some brands I have seen, and Prashant will also agree, that they conveniently hide the elemental calcium. They just write 250 milligrams of calcium, some molecule, and when you actually Google and calculate the calcium percentage, you will find that it's just 80 milligrams per 5 ml, whereas they have written as 250 milligram. And sometimes they will give the concentration in 10 ml. So I'll not take any names, but there are some clever preparations that will give you milligrams, but in small print it is per 10 ml. So we have to read
Calcimax P is 10 ml 300 mg.
Yeah. So we have to read per 5 ml or per 10 ml. That is also important. Not every child requires calcium.
And regarding calcium preparation, having calcitriol, what to do?
Prashant.
Not to be given, sir. Not to be given unless the child is having a hypoparathyroidism, and if at all you want to give that calcitriol, you can directly give Rocaltrol, as we have covered previously, that aspirate through 1 ml syringe and just give it orally, rather than giving a combination of calcium phosphorus, calcitriol. That should not be given.
So 3 indications, sir, for giving those calcitriol based things. Of course, giving separately is a best idea, but then hypoparathyroid, pseudo hypoparathyroid, vitamin D dependent rickets type 1, and lastly patients on CKD, CKD on treatment, where you want to give, there is no 1-alpha hydroxylation. So barring these 3 indications, I don't see any use of those preparations. This one particular study by Dr. Khadilkar and group, Dr. by V. Egbute was the first author. Very interesting paper that tells us that food fortification, if done correctly, can actually achieve a good bone mineral content. So these children, underprivileged children from slums of Pune, were given calcium fortified laddus made of nagli, and it gave 400 milligrams of calcium per laddu, and it actually improved their bone mineral content in 6 months. So not every child requires pharmacological supplement. You can just play around with the diet of the child and improve the overall calcium status. Coming to quickly, we have to rush in next.
Just one query.
Yes,
I have not seen the slide mentioning about the content of the calcium in the ragi or the nachni. What is it? Is it this source of nachni of calcium, and what we can suggest a non-milk source?
So Hari, would you like to take that?
So for ragi, if I remember it correctly, it is around 45 to 50 45 to 50 milligram per 100 gram. That is what I could recall from my PSM lectures. And I don't know about nachni. I mean, how it is made of. But if we see combined cereals, 30 to 50 milligram per 100 gram. That is what has been mentioned as a calcium content. So these are the two. So yeah, two things are having calcium.
Yeah. So nagli is a very rich
ragi and nagli is one and the same thing.
Same thing, yeah.
And it contains 350 milligram per 100 gram. It's the rich source of calcium.
So it's
per 100 grams of ragi. Around
350 milligram per 100 grams. So it's actually better than milk in terms of delivering calcium, and it's cheap and easily available. Particularly in the belt where I live, nagli is a staple diet for many. So quickly we'll go through the hypercalcemia, and with the availability of so many vitamin D brands and including your active vitamin D, nowadays we are seeing a lot of iatrogenic hypercalcemia. So Dr. Hari, what besides vitamin D toxicity do you think of that is common for a pediatrician?
So if we consider hypercalcemia, it is really a Pandora box, and one can come out with any kind of a disorder because right from endocrinopathies of adrenal insufficiency, congenital hypothyroidism, as well as hyperthyroidism can have hypercalcemia. There are basic defects in the metabolism of PTH, in which parathyroid hormone is increased, or there is increase in the parathyroid hormone related peptide, which can lead to eating up of the bone and releasing of calcium in the blood, causing hypercalcemia. So hyperparathyroidism can be secondary to a renal disorder, or it can be secondary to adenoma, parathyroid adenoma, or it could be a part of the adenoma or neoplasm can be a part of Men's syndrome, or any tumor syndrome. So it is hyperparathyroidism which can lead to hypercalcemia. Then there are various paraneoplastic syndrome, various tumor causing paraneoplastic syndrome leading to secretion of parathyroid hormone related peptide, and that can lead to hypercalcemia. Now, vitamin D, increase in the vitamin D ingestion or giving calcitriol inadvertently can lead to hypercalcemia, that is iatrogenic. Now, we have got a variety of rare genetic disorders involved in the synthesis and secretion of parathyroid hormone, as well as action of hormone, like Jensen chondrodysplasia is a skeletal. It is a heterozygous mutation which causes constitutive activation of PTH1 receptor. Here the PTH is low, but it stimulates the osteoclast to continue the bone resorption. Similarly, we have got Bartter syndrome. So many of the renal conditions can have can present with hypercalcemia. We have got subcutaneous fat necrosis or some infective disorders like sarcoidosis, histoplasmosis, or granulomatous disorders, which can actually increase the calcitriol synthesis and can lead to increased absorption of calcium. So hypercalcemia, just to mention that it is a very important thing to gradually approach it, then hypocalcemia, which is a relatively common and a relatively easy thing to reach. A particular mention about subcutaneous fat necrosis: if a child is having asphyxia, birth asphyxia, this subcutaneous fat necrosis can happen in the first 4 to 6 weeks. They are having the subcutaneous fat, it turns into a calcitriol producing milieu. So it usually pours out calcitriol, which increases the calcium absorption. Similarly, next slide, if we can, Tushar. So here we have hyperparathyroidism, the neonatal severe hyperparathyroidism because of inactivating mutation of CASR, the calcium sensing receptor, which actually is inactivated. So it requires more of calcium to actually bring down or shut down the PTH secretion. So there is a hypercalcemia, state of hypercalcemia is there. I had already discussed the multiple endocrine neoplasia, which usually can have parathyroid adenoma. We have got secondary and tertiary hyperparathyroidism, or it could be ectopic prediction of parathyroid hormone related peptide. And again, it's excessive calcium and vitamin D, which can be because of exogenous ingestion or endogenous production, particularly in granulomatous disorders like sarcoidosis, inflammatory bowel disease, or lymphoma or germinoma.
So for a pediatrician to remember two things: first is iatrogenic excessive vitamin D administration, and one important is if you are attending a labor call of a mother who is hypoparathyroid, then you should think of the possibility of hypercalcemia in the baby. So we are pressing upon time, so I'll ask Dr. Sandhya ma'am when to suspect this particular hypercalcemia and how to diagnose.
Yeah, this is, I think, very important for every pediatrician to remember, because we all are used to see more and more cases of hypocalcemia, and we are used to treat also hypocalcemia. So hypercalcemia, surely it needs a very high index of suspicion. So in particularly newborn or infants, if we see growth failure associated with severe anorexia, GER, emesis, persistent constipation, lethargy, hypotonia, irritability, or seizures, and the same infant, if he is having polyuria, particular polyuria with dehydration. So if these all findings are getting together, it is very difficult to suspect actually, because all these symptoms can have a varied type of differential diagnosis. That's why I said it needs a very high index of suspicion. So this simply symptom complex and resistant to your nutritional therapy, resistant to your usual therapy. So you should raise the doubt of hypercalcemia. In particularly neonatal severe hyperparathyroidism, you will get again the same symptom complex with a more severe variety, and you will get respiratory distress due to hypotonia. There can be dysrhythmia due to increased calcium concentration in blood, demineralization, fracture of bones. So these are the extreme symptoms what we can see in neonatal severe hyperparathyroidism. Then these are other symptoms which should raise the suspicion of hypercalcemia, like heart blocks which are undiagnosed, particularly with short ST segment, chronic use of thiazide diuretics for any reason. Then we have to monitor the calcium, because it causes increased reabsorption of calcium from the renal tubules. Unexplained hypertension, as we know that increased calcium level, it causes vasoconstriction. So these children, even infants with persistent hypercalcemia, you can get hypertension. So if you get a child with recurrent headaches, confusion, and if you get hypertension, there is no any reason, you have to see for a high calcium. Then iatrogenic, which is the most common cause of hypercalcemia nowadays, because the child goes from clinic to clinic and from pediatrician to pediatrician, and he gets the multiple doses of vitamin D, 6 weeks, again 6 weeks, and sometimes some pediatrician, if he is very enthusiastic, he can prescribe calcitriol, and the calcitriol usually it is given for short course, even if it is given for correction of hypocalcemia. But the parents can fallaciously go on treating with calcitriol. So this is the most important reason of hypervitaminosis D, which can cause hypercalcemia. Even excess vitamin A supplementation also can cause hypercalcemia. Infants with severe birth asphyxia, as Dr. Hari mentioned, this can cause subcutaneous fat necrosis, and you get multiple tender nodular violaceous lesions or nodules, usually on trunk or limbs, maybe on fat, or sometimes also face also. And there is, due to necrosis, there is calcium deposition. Once the child starts recovering, even in acute phase also, you can get hypercalcemia, and particularly during recovery, this calcium enters into the circulation. It causes hypercalcemia. And rather than that, the most important reason is these are the sites of production of calcitriol, and it again increases the level of calcium, which causes hypercalcemia. Any child with prolonged immobilization, there are many child who are having mental retardation with CP, or maybe spinal cord severe injuries, trauma, and prolonged illnesses. There can be prolonged immobilization, which can again have a hypercalcemia due to increased osteoclastic activity. Any major trauma in older children or disseminated varicella, it also can cause increased osteoclastic activity, and it can cause hypercalcemia. Congenital lactase or disaccharide deficiency causes increased disaccharide content in the intraluminal or intestinal cavity, and this disaccharide again they facilitate the absorption of calcium, so it also can cause hypercalcemia. So next slide. Then these are the reasons what I mentioned in the earlier slide. It was a symptom complex of infant or newborn. In older children, hypercalcemia can present somewhat differently, like anorexia or non-specific abdominal pain or muscle weakness, and even neuropsychiatric symptoms. Even they can face depression, confusion, loss of concentration. Such non-specific symptoms also can be there with hypercalcemia in older children. Then, as Dr. Hari mentioned, Williams syndrome, it is also an important cause. Even if it is rare, you can suspect hypercalcemia with these Elfin phases, which are typical epicanthal fold, then flattened malar eminences, hyperacusis is there, malocclusion of teeth is there. So this is the Williams syndrome, which is associated with hypercalcemia in early ages, particularly around 2 to 3 years. These, or during first 2 years, they face hypercalcemia, and due to that you can get supravalvular aortic stenosis or peripheral pulmonary stenosis, as increased calcium contents causes vasoconstriction and leads to supravalvular aortic stenosis. Then idiopathic infantile hypercalcemia, then tertiary hyperparathyroidism, particularly in cases of renal osteodystrophy. Initially it causes, due to high phosphate load, causes secondary hyperparathyroidism, but if it gets untreated, there can be an autonomous secretion of PTH, and it causes tertiary hyperparathyroidism, particularly in CKD or X-linked hypophosphatemic rickets, and that time you can get hypercalcemia. Or transient neonatal hypercalcemia, as Dr. Tushar mentioned, it is also very important to keep in mind that if the mother is having hypoparathyroidism, then there is persistent increase in the PTH secretion, and this PTH in neonatal age can give rise to hypercalcemia in neonate. Any child who comes with USG of nephrocalcinosis, nephrolithiasis, you have to rule out hypercalcemia. If you see brown tumors or in your skeletal survey or radiological evidence of osteopenia along with metaphyseal widening, subperiosteal resorption, these are the typical radiological evidences, and particularly Brown syndrome or what we call as osteoitis fibrosa cystica. So such type of lesions if we see, then also you have to monitor calcium, and there can be hypercalcemia. So these are the varied symptom complex or varied situations. And lastly, it is the high index of suspicion. You have to keep in mind that these are the presentations, and this can be due to hypercalcemia.
Correctly mentioned by you, all vague symptoms, I don't think one of the reasons for constipation or irritability or polyuria. Yes. How to treat this acute form of hypercalcemia? Most of the pediatricians would be dealing with these patients. Many of them come with ICP or something.
Yeah, can you hear me, Tushar? Yeah. So management of hypercalcemia depends on whether they have symptom or not symptoms and the degree of severity. If it is up to if the serum calcium is up to 12, then there is no need for any treatment if there are no symptoms. But if the level of serum calcium is more than 14 and there are symptoms like anorexia, then we have to treat this particular children. First and foremost, that we have to find out the etiology. The general measures are we have to stop the offending drug, discontinue all the form of calcium, either from the diet or from the supplement, or keep it very minimum. We have to see the offending drugs like thiazoid. In a pediatric setup, the vitamin D is very commonly used and misused and abused drugs. So we have to be really careful. Also the calcitriol. Once we do the general measures, most of the cases which we see are often asymptomatic or very mildly symptomatic. So they generally do not need any treatment. So before we start on the treatment, we have to understand the basic physiology of calcium absorption, as you have shown in the very first slide. For any calcium absorption, there are 3 sites and 1 hormone. One is renal, second is bone, third is intestine or the GI tract, and the hormone is PTH. So treatment also depends on the same 3 sites and 1 hormone. Now, most of the times, 90% of the treatment is based on the kidney and kidney alone. When we talk about the absorption of calcium, briefly we'll discuss the physiology. The reabsorption takes place from proximal tubule and ascending loop of Henle. This process is passive, and this process get enhanced if we give them extra fluid. So that is why the first treatment is giving them the extra fluid in terms of normal saline. So even if we give 1.5 or 2 times of normal saline than that of the maintenance, this passive reabsorption increases and lead to increased excretion of urinary calcium. So that is number 1. Secondly, if we use the diuretic acts on descending loop of Henle, and it will it is generally it will lead to increased calcium excretion from the kidney. We generally prefer the loop diuretic, that is furosemide. We can use it by 1 to 2 milligram per kg per day in divided doses, and it will reduce the serum calcium by almost in the range of 1 to 2 milligram per day. Now, once most of the patients, they are recovered with this particular treatment, that is hydration and max to max loop steroid, loop diuretic. If they are not getting treatment, not getting resolved, and the symptoms of hypercalcemia or the serum calcium levels are high, then comes the next site, which is bone. So we have 2 drugs which we can use. One is calcitonin and the other is peculiar drug, that a very longer acting bisphosphonate. So calcitonin is relatively short acting, rapid acting, can be given as a 2 to 4 international unit per kg, subcutaneous or intramuscular. The advantage of calcitonin is it is very fast acting. It reduces your serum calcium by almost 1 to 2 milligram over a period of 4 to 6 hours. But the disadvantage of with calcitonin is it leads to a tolerance. So once the calcitonin is also used and there's no response, we can use the next drug which is acting on the bone, that is bisphosphonate. Bisphosphonate is a longer acting medication, pyrophosphate component, which inhibits the osteoclastic action. So what it will does is it will reduce the osteoclastic induced apoptosis as well as the function. So it will lead to a reduction in terms of serum calcium level. So once we finish this, then the last site of absorption, that is GI, on that, generally the steroid works. Precisely in cases of chronic granulomatous disorders like tuberculosis or sarcoidosis, which is associated with hypercalcemia, then the drug of choice in such a scenario remains corticosteroid. It will also lead to a reduction of production of 125 dihydroxyvitamin D, which is responsible for secretion of more and more calcium. And very rarely, recently we have come across as a new drug, that is Cinacalcet, which is approved by European Union for the children who are more than 3 years, precisely for renal failure. It is an allosteric modulator of calcium sensing receptors, by which it does have a calcium mimetic action. It lowers the PTH and reduces your serum PTH and thereby serum calcium. The dose is generally 0.25 milligram per kg per day, but I have not really personally used this drug. And very rarely, in severe cases of life-threatening renal failure, hemodialysis remains the final option. So these are sort of all the options that are available, but I will repeat again that 90 to 95% of the cases get away with normal saline and loop diuretics.
Thank you, Prashant, for summing that up. Very nicely. So we are coming to the end of Prashant's slide. He has already mentioned that these are the targets that one should be hitting while treating a case of hypercalcemia. So we are coming to the end of the panel discussion, and I'll summarize by saying that dietary deficiency of calcium is common in children and adolescents. Calcium-rich sources are to be identified and supplemented. Routine supplementation of calcium to healthy infants, healthy newborns, and healthy children is not recommended. Calcium should be given to only those who have hypocalcemia or who are at risk of developing hypocalcemia. So high risk group is the one who needs calcium supplementation. Vitamin D deficiency is a common cause of hypocalcemia at all ages. Acute hypercalcemia is treated better with infusions than boluses. Active vitamin D is only to be used as a tide over in acute hypocalcemia. Otherwise, there is no role of vitamin D active form in acute hypocalcemia. Chronic hypocalcemia needs evaluation and specialty care. So chronic hypocalcemia and hypercalcemia, one must take help of the pediatric endocrine colleagues. And I'll stop here, and I thank personally all my panelists and the team Maha IAP for giving all of us this opportunity to be here. There are a couple of questions in the chat box. If we have time, we can take those.
Yes, just please take.
So there is one question by Dr. Anjali that does rava / suji have high calcium? So anyone wants to take that?
It doesn't have high calcium. It contains almost 15 to 20 milligrams of calcium per 100 gram.
Yeah. So essentially, rava is made from grains, be it wheat or rice. So all the properties of that wheat or rice will be there in rava or suji. So it's not a good source of calcium. One more question: do all full-term newborn babies need calcium supplementation? So Dr. Sandhya ma'am, would you like to answer that?
Not really. Because breast milk, if the mother is having adequate lactation and the child is feeding well, there is no need to supplement. In case of full-term babies, no need to supplement calcium, except the prophylactic doses of vitamin D the child will need. And as we mentioned in our earlier discussion, only for preterm babies, to prevent the osteopenia prematurity, we can give calcium as well as phosphorus. But for full-term babies, there is no need to give routine calcium supplementation.
What about twins or low birth weight babies? Would you be giving calcium?
Not really. There also, if the child is feeding well, there is no need to supplement calcium. Particular indication is the premature child, where we should supplement calcium. I think so. Any views by your side?
I agree. Vitamin D of 400 international units per day is to be given until first birthday. In preterm babies, again, you have said calcium must be given. In addition to that, there may be extremely low birth weight babies who might require higher doses of vitamin D. So some people have advocated doses as close to 800 international units per day. But again, in addition to that, calcium is compulsory to be given. There's one more question by Dr. Anurag Pawar. Do we need to give calcium to each? Yeah, so you have already answered that. Dr. Shakuntal from Nashik is asking, it's an interesting question, that can eggshells be used as a dietary source of calcium?
Eggshell contains calcium carbonate, surely, but I don't think it is really a good idea to have eggshell as a source of calcium.
One needs to find out a good recipe for that. Maybe we should explore that possibility. Yeah. I think we are done with the chat box questions. Hemant sir, Dr. Amol sir, you have any comments or any suggestions? Dr. Neha.
Dr. Jay sir.
Excellent session. Actually, परत मला review करावं लागेल, आरामात परत ऐकावं लागेल व्यवस्थित. Because it's a very vast topic. That is first thing, and lot of because as we deal with all group of ages from neonate to adults and adolescents.
आणि अजून एक महत्त्वाचं की we have spoken about calcium in isolation. We have not touched the vitamin D portion, so it was actually challenging panel to conduct.
Yes. Each time we learn a new thing, but still
very new things
between vitamin D, calcium, as well as phosphorus.
Vitamin D discussion करायचं तर उद्या सकाळपर्यंत vitamin D अंगावर घेईपर्यंत आपल्याला डिस्कशन करत असतो. Excellent. Thank you all, Tushar and all moderators and all panelists. Excellent discussion.
Just one that the question is touched now. So any significant thing while we do our general practice as a general pediatrician, what we do. So any condition where we should take care of, one is giving vitamin D also and one is giving calcium also. Anything, because lots of then multivitamin also has vitamin D, and then calcium pepper is also having vitamin D, and then again the calcium is added. These are all things. So any condition where we should be very careful balancing between vitamin D and calcium.
Who wants to take that? Hari?
So only thing is before prescribing, we should know the previous prescriptions from the other pediatrician from where the patient is coming, because invariably it gets written down as 60,000 IU per week for 6 weeks, and I've seen the patient taking I mean, not for the deficiency, but they have gone for just routine immunization and they are given this supplement. So it has come in a big way that vitamin D deficiency is very prevalent and one should supplement the kids. But then we should know, or at least ask whether the child has taken, or ask the mother whether she has been giving some vitamin D supplements. Beyond that, I don't think there is anything word of caution for vitamin D or giving calcium in particular. I mean, there are no deficiency states usually are very prevalent. Tushar would like to add on that.
Yeah, so giving calcium supplementation, although on one hand we have told that not everybody needs it, but at the same time the calcium supplementation given in the doses around 250 milligrams or 500 milligrams per day is really safe. It does not cause hypercalcemia, it does not cause nephrocalcinosis in the doses that we are using. So it's safe even in pediatric age group and adults. In adults also, I was going through the literature, they have said that remote possibility of prostate cancer is associated with calcium use, but it's a safe drug when given in the doses of around 250 to 500 milligrams per day. Vitamin D, particularly in the history, we should ask, has the patient visited any orthopedician? Because orthopedicians still have the practice of giving 6 lakh international units injectable doses. So after I ask, have you shown to any orthopedic surgeon, they will pull out 2 files and then they will show की याला पण दाखवलंय त्याला पण दाखवलं. So they might have taken already large doses. Dr. Sandhya, Dr. Prashant, would you like to add?
Yeah,
to that?
definitely, Tushar. So 6 lakhs, we see patients most of the times receiving 6 lakhs from the orthopedic colleague, and invariably they will have a hypercalciuria.
Yeah.
And vitamin D toxicity. So suppose if we check their vitamin D, it's more than often in the range of 200, 300, and calcium in the range of 12 or 13. So that is very prevalent.
Dr. Tushar, I have one question.
Yes, sir.
Already you are recommending deficiencies 1000 and 2000 or 3000 that units per day. You should be assuming, right?
Correct.
But what about the 60,000 units per week for 6 weeks? And in that, suppose you advise 60,000 units per week, when should do the serum vitamin D in this patient to confirm whether this patient is responding or not responding?
Yeah. So the guideline, the recent one, mentions that you should repeat the biochemistry, that is the calcium, phosphorus, alk-phos, and the radiology. But after giving these 6 doses, it is not generally recommended to do the level again.
Okay.
If the biochemistry has settled and the X-ray shows healing changes, you need not repeat the vitamin D level.
We are talking about the rickets, or rather we get some patient of adolescents with severe vitamin D level, less level, low level, right? Below 10, something very severe deficiency of vitamin D days. No, obvious patient is asymptomatic.
Right.
Still we give the 60,000 units per week, same or 2,000 or 3,000 international units of vitamin D per day for 3 months.
So there is a quick mention about repeating the biochemistry at 12 weeks, but I'm not really sure whether by biochemistry they mean vitamin D levels.
This is calcium session.
Calcium cannot be discussed without vitamin D.
I understand. Yeah.
I have a question.
Yes,
please. Patients who are on vegan diet or are are having lactose intolerance, how frequently should we check calcium for them?
Who wants to take that?
No.
Lactose intolerance in case of infants, or lactose intolerance, what you usually see lactose intolerance in infants. What we mentioned is disaccharide deficiency. Usually it is the condition causing hypercalcemia. So are you asking about hypercalcemia or hypocalcemia? Are you concerned about hypo or hyper? Hypo. So in lactose intolerance, hardly it is not the situation where should we get hypocalcemia particularly.
So I was, going through some non-medical papers, and evolutionary, the journey of human race through evolution. So this idea of drinking milk is quite recent. There is no other animal other than human beings that drinks the milk of other species. So we don't need milk, firstly. Secondly, the calcium intake of human race was much better before the agricultural revolution. So we used to eat all kind of raw vegetables and a lot of animal based proteins, lot of seafood, and that was quite rich in calcium. We did not use domesticated animals a few thousand years ago. So there are a lot of good sources of calcium other than milk. So vegan diet, of course, B12 is a major issue than calcium intake if you talk about the vegan diet.
Dr. Tushar, lot of Haryana sports person getting medals in this even Commonwealth Games. So we had a lot of WhatsApp. The child is drinking directly from the handi of this.
Yeah, I saw that.
2 liters of milk or 4 liters of milk a day.
Even MS Dhoni, yes. क्यों इतने सिक्सर मारता है? He drinks 2-3 liters of milk every day. Right.
No,
No.
it may be on a lighter way, but really it means we hear a sports person telling we drink 2 liters of milk a day. Is it means it is useful working or what?
Still, I drink one
Because
one glass of milk every day.
they become brand ambassadors to the children, to the parents, to give the milk to the children.
I think
Virendra Sehwag.
milk has got protein in it and as well as calcium, so it is going to increase the bone accurately and all. So definitely making your bone stronger. Since childhood, we also must have heard. Everyone must have heard about drinking milk for having strong bones and good teeth.
Sir, I have taken
ICMR
milk
mentions 500 ml per day, not beyond that.
Yeah.
Sir, me
Yes,
250 ml.
yes, we are talking about the science. Means what science say? You say 500 ml a day. Dr. Tushar,
Yes, sir.
you said ICMR says science is only
Five-
500 ml a day.
Yeah, so that is sufficient enough to mitigate the needs of calcium for a child.
Up to age of 30 years, I have drunk this half liter of milk every day. Still, I drunk पाव liter of milk in the morning every day. Marriage नंतर नियम असायला तर रात्रीचं दूध बंद तुझं काय पे additional. That's
On the other side, sir, there are a lot of autoimmune disorders that are linked with animal milk. So we don't know how much of asthma, how much of type 2 diabetes is going to develop into these children who are drinking a lot of milk.
right.
Chalo.
We had an extremely very nice discussion today about calcium and vitamin D. Now we proceed for
Yes.
the vote of thanks.
Yes.
So I invite Dr. Amol Pawar, sir, our Secretary General, for the vote of thanks. Over to you, sir.
Yeah, thank you, Neha. Thank you, Dr. Tushar, Dr. Hari, for coordinating in conduction of this webinar, along with Dr. Prashant Patil, sir, and Dr. Sandhya ma'am. Lot of thanks to you all for taking pains in preparing such an informative question answer session with slides filled with a lot of minute details about the calcium. I'm sure such a detailed discussion must have solved the queries on calcium of all general practitioners, the queries which come across in their daily practice. I again thank you all thank you all of you from Team MahaIP. Thank you all delegates who were present on Zoom and YouTube, viewing such a detailed discussion on calcium. Thank you, and good night to all.
Good night. Bye bye.
Thank you everyone. Good.